with and collaborate with Dr. Parker on is the outreach, recruitment, and education core. And so, as the name implies, we tried to be the outer-facing element of the ADRC. The ADRC is one of about 30 that's funded by the National Institute of Aging to pursue three missions: to identify ways to detect dementia illnesses, to participate in research leading to the cure and treatment of these illnesses, and also to participate in research that enhances the care provided to persons living with dementia illnesses and to the caregivers, the family caregivers and professional caregivers who provide assistance to the lives affected by dementia illnesses. What we try to do as a core is keep the public at large abreast of developments in Alzheimer's research, to continue to say that work is being done vigorously, hope is springing eternal. We hope that some very good things are going to happen in the near future. So part of our mission is to provide information, but a large part is to inform individuals of opportunities to take part in research at Emory, or sometimes at other institutions with which we collaborate. So a lot of our research is basic in nature. It involves treatment treatment trials, or it involves trials where we're looking at underlying physiology to see if there are ways to detect Alzheimer's in preclinical, Alzheimer's and other dementias in preclinical stages, because the emphasis now really is to try to identify people whose risk factors have moved them into a kind of a preclinical stage of a dementia illness. And people around the country and around the world are targeting intervention development activities at persons at those stages. So we want to involve people who are not showing signs, who are middle-aged, who might be at risk, and engage them in research to see if we can be better at detecting people who are in high risk. We have trials of treatments, and all of those involve different levels of participation. It could be, some of it could be just at the level of surveys. A lot of it is more clinical involvement with lumbar punctures or magnetic resonance imaging and things like that. We also have a lot of trials of studies for family members, family caregivers. And I'm just gonna, if I can, I don't know if I can share my screen. Nope, somebody let me share my screen. I'm gonna talk about one such study. There's a whole family of studies ongoing or about to begin around caregiving. And here's one. It's a program we've put together called Caregiving During Crisis. It is fully online, self-paced. It's like a continuing education course for caregivers. Talks about how to protect yourself and the person for whom you might be providing care. You know, during this pandemic, and we don't really know that this pandemic is over. So there's a whole section on safety. There's a very large section on navigating the healthcare system for yourself, but really for the person for whom you're providing care. And on managing life at home with a person living with dementia. There's a email address that I'm going to put in the chat box that if you're interested in this or any other any other research that's going on around caregiving, just send us a note, and we will get in touch with you and give you more information, and ideally enroll you in the study. So that's what we do. We have events like this. That's what we do in the Outreach, Recruitment, and Education Corps. We have events like this. We have other public events. We have a website that we keep very up to date with a lot of research opportunities. And we try to make it as easy as possible for you to get information about the research studies that we have available through the ADRC. And we are eager to help you enroll in those studies. So with that, I'll turn it back to Monica, who's going to introduce other members of our Alzheimer's Disease Research Center.
Thank you so much, Dr. Hepburn. At this time, I'd like to introduce to you Dr. James Law, who is the director of the clinical core here at the Goizueta Alzheimer's Disease Research Center. And the clinical core is that core which is responsible for the actual conduct of research. You know, there are places that do it, but the clinical core is the core that helps decide what your clinical status is. If you're one of our research participants, you'll hear the words control, which is somebody who has no memory problems. You'll hear MCI, which is mild cognitive impairment, and you'll hear dementia. So those are three terms that we use in the clinical core, and through our collaboration with other centers around the country, we have a weekly meeting where we look at some of our research participants and we put them in categories of control, mild cognitive impairment, and dementia. And we also look at what studies might be of benefit to them when I say of benefit, something that they would be eligible for to participate in terms of research. If you've been following us for a long time, you know that all research studies aren't applicable for everybody. If you are interested in a drug study, you must be a patient being followed by a clinical neurologist here or someplace else. But to be eligible for a drug study, you must already have a diagnosis of Alzheimer's, mild cognitive impairment from whatever etiology. And between the neurologist, we decide what study is most appropriate for you. So to help you understand more about what we do in the clinical core here at the Goizueta Alzheimer's Disease Research Center, ADRC, we're letting you hear from Dr. James Law. Dr. Law.
Slide, and this is, I just used this to demonstrate what our challenge is, and I'm going to introduce a couple of concepts to you. But that bottom graph is a graph of life expectancy in the United States from about 1900 to 2000. And you can see it's pretty much a straight line, and that line hasn't flattened out. We're still living longer. And the top graph just shows you how frequently people in different age groups develop these dementing disorders, particularly Alzheimer's disease, and it is powerfully driven by your age. And so if we live longer, our risk of developing disease is going to be longer. Now, I don't know if that went twice or once. Now, this is a concept I want you to understand. So in the top part of that picture just flashed up, the top half of it, shows what happens with increased longevity without changes in disease. So that red colored area can represent Alzheimer's disease or any other age-related disease. And if we live longer and we don't do anything about those age-related diseases, what happens? There's going to be more of us that have those age-related diseases. And the bottom part shows what happens if we introduce something called disease-modifying therapies. That means things that will impact the development, slow the development, or slow the progression of disease. And it doesn't matter what it is. It can be heart disease, it can be cancer, it can be Alzheimer's disease. And so that green and yellow area I want you to think of as the health span of a person. Not the lifespan of a person, but the health span of a person. And I don't know about you, but I would much rather have a longer health span than a longer lifespan. I don't want to spend the last 40 years of my life debilitated. And so that's where we're working towards. So with Alzheimer's disease, there's a lot of things that we know. There are risk factors. Aging is far and away the most powerful risk factor. There are a host of genetic components, so genes that can contribute to your risk of developing Alzheimer's disease. And one of the most critical decisions that you can make if you want to avoid getting Alzheimer's disease is be highly selective in your choice of parents. Okay? Because that is going to contribute an enormous amount, and that's why family history is so important. Gender. Women do develop Alzheimer's disease at a higher rate. Head injury, Dr. Parker mentioned about chronic traumatic encephalopathy, but we also think chronic head injury, repeated head injury will put you at risk of other degenerative brain diseases, including Alzheimer's disease. Vascular disease, cardiovascular disease, all of those things play a very important role, as does lifestyle. Some of those factors, like your selection of parents, is not under your control, and so there's not too much you can do about that. But some of the lifestyle factors and vascular conditions are very much under your control. So let's talk about those things for just a minute. Actually, we went to Coca-Cola recently, and I had a slide like this. And initially, the obesity picture had a Coca-Cola logo. I decided I'd better make that a Pepsi logo. But anyway, these things, obesity, type 2 diabetes, heart disease, hypertension, all of those factors that impose a certain amount of stress and strain on our bodies as we get older will also put stress and strain on your brains and increase your risk of developing Alzheimer's disease and other degenerative brain diseases. And so those are all factors that you want to make sure you control. And you know how to do some of those things. Attention to preventive medicine is critical, and so men are, always a minority in our audiences, and so it's contingent on you women to go home and educate your men, because men we're just dumb. We don't go see our doctors. We don't pay attention to prevention messages. So it's up to you to make sure that your man lives long enough to, maintain you in the lifestyle to which you want to be accustomed. But there are things that you can definitely do in terms of controlling some of those risk factors. There is a tremendous amount of research emerging right now suggesting that aerobic exercise and aerobic fitness is absolutely critical for brain health and also for prevention of degenerative brain diseases. So much so that there are studies that are emerging right now, including one that our colleague Dr. Wharton is leading here at Emory, that's looking at aerobic exercise and fitness as a prevention method for Alzheimer's disease. And this is just one of a number of studies that have looked at the effect of exercise. And there is really solid scientific evidence that exercise will actually reduce the cognitive symptoms associated with aging and also with Alzheimer's disease. That picture reminds me, I heard Ted Turner give a talk once a while ago, and he says, your brain is a muscle, just like any other muscle in your body. Well, it's not a muscle, knucklehead. However, you do have to exercise it like the muscles that you have. Now, so exercise is critically important. Diet is something we also preach. There is a lot of evidence that heart-healthy diets, Mediterranean diets, actually can reduce your risk of developing cognitive impairment and dementia. And this graph just shows the curves of individuals who develop Alzheimer's or other dementia symptoms, and plots it relative to the type of diet that you had. So the people on the top line that had the lowest rate of developing Alzheimer's disease had the most heart-healthy diet with the components that we think of in a Mediterranean diet: fresh vegetables, less red meat, less fats, less processed food, more fish, and other healthy foods. And this, I don't know if you can appreciate this. You guys are all pretty much neurologists by this point, right? Okay, good. So What this shows, though, is actually a representative picture of two brains. And the picture on the left is a person who had a more Mediterranean heart-healthy diet. And the picture on the right was a person who had a poor diet, a not heart-healthy diet. And those arrows point to little gaps that show up as dark spaces. Can you see that? There's a difference between the two brains. And those dark spaces represent shrinkage of the brain. And so people who maintained a healthier diet, healthier lifestyle, actually have physically measurable differences in their brains as a consequence of those lifestyle choices. This thing's gonna drive me crazy. I'm just gonna just skip past this slide, but it just shows the kinds of things that we deal with when we actually deal with patients who have dementia and Alzheimer's disease, and that is that progressive deterioration, which is so terrifying. And it's really, one point that I want to make on this slide is if you look at some of the descriptions on the far right of the slide in individuals who have severe dementia symptoms due to Alzheimer's or anything else, that's the point that's so scary. When you've lost quality of life, ability to interact in a meaningful and enriching way with your friends and families. Earlier on in this process, when people have mild cognitive impairment, the very earliest stages of memory loss, quality of life is excellent. Very few, if any, functional limitations, just maybe some annoyances in terms of memory loss that's sometimes hard to distinguish from normal aging-related changes. And even in mild stages of Alzheimer's or other dementias, the symptoms are relatively mild. But it's that last portion of disease that's so scary. And so
Thank you, Dr. Law. I hope that's been a good primer for those of you who haven't tuned in before, and that you understand and appreciate that everything that goes on with brain dysfunction or dementia is not something that you have no control over. Yes, if you have genetics and if you're female, you're more likely to develop Alzheimer's disease than not. But at the same time, there are things you can do to protect your brain. Chief among them is participate in daily aerobic exercise. Our recommendation is 150 minutes a week. And engage in a heart-healthy diet, most consistently the Mediterranean diet. We want you to preserve your brain function, and in order to do that, you need to do everything you can to keep your overall body healthy. We've always said, and this is why we have John here, what's good for your heart is good for your brain. Our next presenter is Dr. Ihab Hajjar. Dr. Hajjar directs our clinical trials unit. He is also an internal medicine doctor or geriatric primary care provider. He's got many different studies that are going on here at Emory. A lot of them involve hypertension and cardiovascular disease and their risk association with the development of dementing disorders. Dr. Hajjar.
Thank you, Dr. Parker, and welcome to our Gozweda ADRC forum. I was asked to give kind of an overview of our clinical trial program. The clinical trial program is a very important program of our center because it's the place where we are testing different interventions, and also the place where you have access to some of these interventions. Am I controlling the slides, or you are? So can you go next slide? All right. So what is going on at this point in the field of treatment of Alzheimer's disease? So as you may know, it's been many years since any new drug has been approved. Today, there are about 3, maybe 4. One of them is not being used, but 3 drugs that your doctor can prescribe for you or for your family if they have memory problems or Alzheimer's disease. And these include drugs that are what we call symptomatic therapy. In other words, they basically temporarily slow down or may affect the way the memory loss is progressing. Unfortunately, these drugs that are available, they don't stop the process of that's underlying the disease. So Very similar to, for example, when you take a blood pressure medicine, it lowers your blood pressure, but when you stop the medication, the blood pressure goes back up. And although it may not be very similar to that, but these drugs are actually symptomatic therapies. They don't cure or treat the underlying illness, and they also don't cause what we call modify the pathology or the disease process that's underlying in the brain, that's all going on in the brain. And there's been a lot of effort in the past decade to find such a medication. We want to find something that is going to go and stop the brain from having increased level of the gel substances that causes nerve or neuronal death, which is called amyloid, and subsequently to that produce the protein that's called tau. Both of these can cause some significant damage to nerve cells, and these eventually lead to memory problems. And if you are following the news at all, you would know that there's been a lot of talk about the Biogen drug. This is probably the most promising medication that has been advancing in the pipeline of approvals. And at this point, there's been a recent, in the last year, some discussion about possibly approving that drug. It's called aducanumab. However, as you may have heard, there were a lot of controversies about the data provided to the FDA to get the drug approved. There's been a lot of concerns about the safety or the validity of this data. There were two studies. One study was positive, one study was not. So the FDA has been giving us different deadlines, and the most recent is they are going to give us a decision in June 7. And interestingly, if you follow the history of this drug, you could see, you can see that the Biogen stocks have been pretty much parallel to the way this drug has been approached or covered in the media. So when there's a news that the FDA is probably going to approve it, there's an increase in the stock of that drug, of that company. And then if there's talk about possibly not approving, there's a dip in the stock. So that's a very interesting area that if you are observing or watching the stock market, that's of great interest. All right. So with these limitations, what have we done or are doing at the Alzheimer's Disease Research Center to address the lack of progress and the lack of new drugs that providers can prescribe to patients with dementia and Alzheimer's disease? So for one, I think we have a unique situation at our Atlanta Center, is that we have a program that's dedicated to conducting clinical trials in Alzheimer's disease. So it's part of the Alzheimer's Disease Research Center, but we have a dedicated program that's testing various compounds and drugs, so either new drugs or existing drugs in this area. We also have, parallel to that, a unique physical space, which with a dedicated staff, a highly diverse and experienced individuals, investigators, and healthcare providers all working together in the pre-COVID in the same space, but now in a virtual space to study and investigate new things that we can do and to give patients who have memory issues. And one of the goals of our unit is that we want to provide as much number of studies as possible so that individuals who come to us can choose the study that is fit them, and along working with the investigators and their providers, they can identify the study that they feel comfortable with participating in and potentially provide some benefit from research participation, as well as access to drugs that otherwise they may not have access to if they were to see their providers. And I think of these as three different categories of things that we are testing. One is new drugs that pretty much have not been approved. They are being in development and they are at various stages of development. These are typically funded by companies, pharmaceutical companies, in order to get the drug approved and available to patients at the bedside. We also have a program or a strong program or a big program in testing drugs that already are on the market for other indications such as high blood pressure or diabetes or asthma, and see if we give them to people with Alzheimer's disease or dementia, whether they help them or not. And then there is a third group of interventions, which are the interventions that are not necessarily a pill or a shot that you get, but things that you can do in terms of lifestyle that might help memory. And if you haven't been in that space, we are on at Executive Park. Our space is at 6 Executive Park. It's a space that's clinical research studies are being conducted. We were affected by COVID as most other centers and the whole society. We are ramping up. It may take a minute for us to catch up to what we have lost in terms of time, but we are definitely on the path to regain full capacity in the next few months. We have a wonderful team of investigators and staff that are working together. These are before, in the good old days, when we were able to have 3D meetings, when we used to get together, and these are some pictures from the forum that we were able to, that are all working together in order to get some new interventions and new medications available for patients and for individuals. All right, I wanted to give you just a brief summary of the various drugs and medications and interventions that we are testing at this point in the clinical trial program. As you may know, most of Alzheimer's therapy is focused on trying to clear or stop the production of the plaques and tangles. So we have multiple drugs that are being tested that are targeting the amyloid and targeting the tau, which are the main components of the plaques and tangles. We are also studying drugs that could be prescribed right now to see if they prove effective. One of the drugs that I have been testing and studying now for about 10 years with significant advance in the effectiveness proof of effectiveness is candesartan, which is a blood pressure medication. We have other drugs that are being tested, such as aldactone, which is another blood pressure medicine. We have a study that's looking at the effect of metformin, which is a diabetes medication. We think that metformin, if it's given to people with mild cognitive impairment, it might slow down their progression into the various advanced stages of dementia. We are testing a drug that's called montelukast or Singulair. It's an asthma drug. It has a very strong anti-inflammatory effect. And we know that with Alzheimer's disease, there's an increase in inflammation. So the idea here is that if we stop inflammation, maybe we can slow down the disease. And then finally, there's a study that was recently completed for using a drug used in ADHD that might have an effect on patients with Alzheimer's disease called atomoxetine. We also have a set of non-pharmacological treatments that are being tested. Supervised exercise, collaboration with the multiple YMCAs here in the city. We're doing a study along with, it's a national study that is looking at the effect of structured exercise program in preventing further decline in memory in patients who have memory loss. We have a study on dance, particularly tango dance. The coordination in tango seemed to help memory. Stress reduction, and then we have a program that's funded by philanthropy and the Fox Foundation, which is called the Cognitive Empowerment Program. And that program is providing resources and educational methods to people to address mild cognitive impairment and memory loss. So how, okay. All right. Sorry. So how can you take advantage of all these opportunities here in the greater Atlanta area is kind of participate in sessions like these to get to know about the different studies that are being conducted. Reach out to one of our staff or our investigators. I have put here my email, so feel free to email me if you have any question about any particular study, and I can connect you with the right person. If you have a primary care provider or seeing somebody in a consultation service or provider, raise the issue of participating in research for memory problems. And then if you agree and you find that to be helpful, then you can participate in a research study. So,
Dr. Hajjar.
Yeah.
There was a question, I'm not sure, this is Monica, I thought you might have missed it. Would you kindly comment on things like Prevagen? That's one of the questions that's in the box. Are we doing any studies on Prevagen? And can you just kind of help guide that discussion? Thanks.
We're not conducting any study on this particular compound. I'm not that experienced in the research background for this drug. It's definitely highly publicized. You see it a lot, advertisement on daytime television. It's some of the evidence when I reviewed that a while ago is coming from mice. I don't know if there is a strong human evidence that it actually helps. So it's very expensive or somewhat expensive. So there's always the concern of spending, that money on a drug that could potentially not be effective. I think the jury is still out there whether this is going to prove to be effective, but we are not in our site, and I'm not sure if there are any ongoing studies in that compound, but it's definitely one of the most commonly asked questions and most commonly advertised drug for Alzheimer's disease and memory.
Thank you.
Any other questions?
I think we want you to look in the chat and see if there's anything that you can answer.
Okay.
Okay.
All right.
Well, thank you so much, Dr. Hajjar. Did you see something you wanted to answer?
I didn't see any questions at this point, but I'll keep reading, and if you have a question, just type it in the chat, and I'm happy to answer it.
Okay. And again, Dr. Hajjar gave you his email, and we'll probably be putting that in the chat for you to access a little bit later. But any of our presenters are going to give you some contact information. Please take your notes and write these things down so that you can contact us later. Our very next presenter before we get to our stretch break is Dr. Alvaro, excuse me, I said his name wrong, our statistician who runs our data core, Dr. Alvaro.
Thank you. I will need to share my screen.
We're going to make you a co-host.
Okay, yeah. There we go. Thank you so much. Okay, and let me just close this. You don't need this. We have me here, and let me just get us started. Thank you so much, Dr. Parker, for the introduction. My name is Alvaro Alonso. I'm a professor of epidemiology at the Rollins School of Public Health here at Emory, and I am one of the co-directors of the Data Management and Statistical Core. And what I just want to do briefly today is give you a brief overview of what we do here and just give you a couple of examples of some of the activities of the work that we do that is related to Alzheimer's disease and other dementias. The main goal of the Data Management and Statistical Core, or the Data Core, is provide support to Emory investigators and other investigators outside Emory that work with the Alzheimer's Disease Research Center in terms of organizing, storing, and having good quality data. So for example, Dr. Hajjar earlier, Dr. La earlier talked about the different studies that are being done at the ADRC. We contribute to keep those data secure in good quality, share with investigators, and assist investigators in that process. Briefly, that's the overarching goal. The specific goals of the data core are three. One, as I mentioned, is to maintain the databases that support ADRC activities and investigators. As you can imagine, when clinicians and research staff are collecting data from participants, those data have to go to databases. So it's important that the databases that collect those data are organized, accessible, so we can make the most of those data that participants are providing, helping us to move the field forward. So that's part of our work. The second important thing that we do in the data core is to provide methodological support to investigators in the ADRC. And this methodological support means, one, providing statistical support. Many of our investigators in the data core are biostatisticians that have experience with data analysis, with statistical analysis. Many of the types of data that we collect can be complicated, so our researchers contribute to help other investigators to analyze those data. In addition to providing that statistical support, we also help investigators that want to do research on Alzheimer's disease and other dementias. We help them to design their studies in a way that they can get the answers they need to the questions they want to ask. It's important when we are doing clinical research, when we are doing research in the population, that the research projects are properly designed so we can get answers that are not going to be biased, that are not going to be wrong. And we provide that support to help investigators that may not have that expertise to do that. And the third part of the data core is to develop new methods that will support research on Alzheimer's disease and other dementias. As I will show you briefly later, we are collecting more data than ever. We are measuring more biomarkers, more different aspects of human physiology, human pathology than before. That is leading to lots of data. And many times the tools that we have had in the past to analyze those data and make sense of those data are insufficient and are not adequate to this new area. So many of our investigators are also contributing to develop new methods that will help us make the most of this new data, and will support other investigators in other cores within the ADRC. The clinical core, we'll hear later about the biomarker core, other cores that conduct research. We help them developing these new methods. In this next slide, I wanted to show you some examples of some of the activities we are involved with. First of all, one of the main aspects of the work that is done within the data core or within the ADRC is participation in the National Alzheimer's Coordinating Center cohort. This is a cohort that a group of patients and controls, individuals without dementia that have been followed over time across all the ADRCs in the nation. And Emory has contributed close to 1,000 participants in this cohort. And these are individuals who have dementia, including Alzheimer's disease, individuals who have mild cognitive impairment, people with normal cognition that are being followed over time using standardized approaches. We contribute to collect that information and share that information with the coordinating center nationally, so investigators across the US and outside the US can use that information to answer questions related to the prevention and development of Alzheimer's disease and other dementias. So that's one of the main things we do. We are also helping investigators that work on different research questions around the development of Alzheimer's disease. So for example, in the last year, we have had several researchers within Emory that are interested in answering questions about the relationship between air pollution and dementia. Our researchers are helping them to design studies that can answer those questions. So for example, we are working with some investigators at the School of Public Health that are evaluating how, when we look at the US population as a whole, how the levels of air pollution that obviously are going to be different across different areas may affect the risk of developing a dementia. We are using very large databases in the US. Other studies that focus on this are interested in understanding, for example, the mechanisms of how air pollution can affect the brain. So we have investigators that are measuring air pollution in participants in different studies within the ADRC, and they are trying to see how those levels of air pollution that we are exposed to may have an impact on brain structure and brain and other parameters within the brain. So this is just an example of one of the studies in which we are involved. Another area that is important within the data core in terms of providing support to others and in terms of providing new methods for the analysis of data is the area of biomarkers. By biomarkers, we mean markers that we can measure in, for example, in blood or in the cerebrospinal fluid using a lumbar puncture, a spinal tap, and those biomarkers can help us understand who is at higher risk of developing Alzheimer's disease in the future. So maybe we can provide earlier interventions that can prevent the development of dementia, right? So we are helping to identify those biomarkers with the methodologies that we are using. An example of that is the study of genetic data. As I mentioned, we have more and more data that is being produced regarding genetics of dementia and Alzheimer's disease, not only genetics, but other factors that we can measure around the genes that are related to the DNA and other similar aspects. And we have lots of data coming from all those studies. So as I mentioned earlier, we have issues sometimes being able to analyze those data and answer questions properly. So our investigators are developing novel methods that provide that allow others to use genomic data in the most fruitful way to answer questions about the etiology, the causes of Alzheimer's disease and other dementias. One of those examples has been, for example, the use of machine learning. Now it's all very fashionable to talk about machine learning, artificial intelligence. So some of the applications of these approaches to medicine and clinical research involve the use of different types of data, for example, genetics data, imaging data, clinical data, and pulling all those types of data together and using novel approaches that are based on machine learning techniques to identify patterns across the data that could help us see who is at higher risk of dementia, and not only that, but also potentially identifying new pathways that lead to the development of dementia. So those that are conducting studies in the laboratory to develop new treatments can focus on identifying those new drugs that could affect those targets. So that's another area that we are working on. And with that, I will be happy to answer some questions if you have any.
Dr. Alonso, can you help us a little bit with some of those studies on pollution, where we can probably access some of those? Because that's one of the, according to the Lancet Journal, that's one of the risk factors for dementia, living in an area that has a high degree of pollution. It's one of the now 12 modifiable lifestyle risk factors. Where are we doing that here in Atlanta? Where can we get involved in a pollution study?
So, thank you. So many of these studies that focus on pollution, what they have done is use large national databases. And the reason to do that is because everyone living in Atlanta, obviously, there are going to be differences across different areas of Atlanta, right? But we are more or less exposed to the same levels of pollution. So in the end, the studies that focus on pollution need to have information from multiple cities or multiple regions across the country. For example, we know that many areas of California have much higher levels of air pollution than some other areas, maybe in the Midwest. And then using those national studies, we can compare the risk of dementia depending on the environmental levels of pollution. Some of the studies that our investigators are doing, though, are using data already being collected for other studies within the ADRC. And what they are using is, for example, studies of participants that have eventually have donated their brains for research. We are able to use those brains, and we are able to use information about prior history of air pollution exposure in those individuals, depending on where they live across their lifetime. We have been able to collect that information so we can explore that. And in addition to that, obviously, we have studies that participants that are involved in other studies, and we can use the information they provide to us to answer questions around it. So I will say that in general, just being involved in many of the studies that are going on at the ADRC is going to help us to address some of these secondary questions that we could develop later on based on the data that are being collected.
Thank you so much, Dr. Alonso. And if you wouldn't mind, there are some questions in the chat that may be applicable to you. And at this time, Dr. Alonso, Dr. Hajjar, any of us who are on this program today will answer the questions that are applicable to us. And as soon as this program is over, if there's some remaining, I will answer them for you. We are now at a point in our program where we have a 5-minute stretch break. No, John, you just get up and go to your refrigerator and get your drink and your rest break. And we'll be back in exactly 5 minutes. Thank you. We're rejoining our Goizueta Alzheimer's Disease Research Center's 20th forum virtually. This week is part 1. Next week we're having part 2. You will hear from some additional members of our Alzheimer's Disease Research Center team. We'll talk about pathology. We're going to talk about some studies that are actually ongoing, some of the investigators that are actually working under our umbrella. And you'll also hear from an organization called Us Against Alzheimer's. They have a new brain guide, which they're going to teach everybody to use that helps us identify resources in our respective communities. We do appreciate that many of the people that are on our call today aren't necessarily in the city of Atlanta or the state of Georgia, and you may be living in some other state. So we were giving you resources as well. Our next presenter is going to be Dr. Felicia Goldstein, who is a neuropsychologist. So in some of our talks, it's like, what do you need to do to get an Alzheimer's diagnosis? Well, there's no one single test that we can give you that gives you a diagnosis of Alzheimer's or any other dementia. It's a process. And part of that process involves your primary care provider, whether you see a geriatric doctor, an internal medicine doctor, or a family medicine doctor. And that's because part of the medical workup is to look at things that may look like dementia but may not be. Maybe there's a medication that needs to be adjusted. Maybe depression needs to be evaluated and treated. So there are medical things and even vitamin deficiencies that can be associated with the onset of dementia, can look like dementia, but they're not. And so you need your primary care doctor to work on that. In addition to a comprehensive medical visit to rule out those things that can be treated, you need to have a brain image. And as Dr. Law pointed out, as Dr. Hajjar alluded to, you can have a brain image. That brain image is almost always going to be an MRI of your brain, depending upon what part of the country you are living in and what kind of resources are available in your community. You might have a PET scan, which looks for the plaques and tangles that are associated with Alzheimer's. So you have a comprehensive medical exam from your primary care doctor, you have a brain image, an MRI or a PET scan, and then you have something called a neuropsychologic test. This is a test that's done by a neuropsychologist like Dr. Goldstein, who's going to be next, who does the testing of your brain to see what different functions your brain is capable of or not, as the case may be. Dr. Felicia Goldstein is a professor in the Department of Neurology. She's internationally known for her work in neuropsychology, and more specifically, she has developed norms for people who live in rural areas as compared with people who are not, people who are African American versus people who are not. So a lot of the testing that's been developed for Alzheimer's and related dementias was developed largely with European Americans, well-educated European Americans. And as we've gone on and included more people in research studies, we need to adapt these studies to be more applicable to the different populations that are in our country. At this time, I'd like to introduce you to Dr. Felicia Goldstein, who's going to present next. Dr.
All right,
Goldstein?
thank you, Monica. I'm going to try to share my screen. Hopefully I'll be able to show my slides. Can you see this slides at all?
You have access, Felicia. She says you're sharing screen now. You're a co-host.
Okay,
but your screen's
great.
not up.
Can you see it now?
Click the share screen button, please.
Okay, hang on, guys. Sorry. All right. So
That's me. That's me.
I will be there in a minute. Share screen. Okay, I've got that. And this should work, I hope. How's that?
Yay, you go.
Yay, good. All right, you can tell that technology is not a strength of mine, but I am learning for the COVID stuff. Can everybody see that okay?
Yes.
Okay, let me go back to the previous slide. So thanks for inviting me to speak about the clinical core. As Monica mentioned, I am with the Alzheimer's Disease Research Center. I've been at Emory for many, many years. I got my degree here and then stayed on when they were forming a newly developed geriatric program for people with dementia. And back in the old days, we didn't even have Aricept. So I've just been amazed at how the field has grown and how positive we are in terms of finding new treatments and new approaches, both pharmacological and non-pharmacological, such as diet and exercise, that are actually showing some benefit. This slide just summarizes all the components of our Alzheimer's Center. It's pretty busy, but I really wanted to emphasize the interaction of all of the cores. The clinical core on the left, directed by Dr. Law. Dr. Hajjar and I are co-directors of the clinical core. You could see we've talked with about the data management, the outreach and engagement cores, and all of the different cores all work together. So we are interacting constantly. Really, the clinical core perhaps relies especially on the outreach and engagement core and the minority engagement core led by Dr. Parker, because these cores are the ones that provide education to the community, but also help identify participants for us in our Alzheimer's Center who can be in studies and are willing to donate cerebral spinal fluid and brains ultimately, which neuropathology is so critical to advancing the field. So we're very grateful to the folks who are willing to do that for us. So the clinical core has a number of different functions. One of them is to establish and to maintain a diverse cohort of well-characterized research participants to support priorities in current Alzheimer's disease and related disorders research. One of our most important roles is we work closely, as I said, with all of our cores to engage and retain a diverse group of research participants. We are very focused on recruitment, particularly of African Americans. This has been a strong priority of our clinical core for many years. We definitely have been successful compared to other cores across the country, thanks to the efforts of Dr. Hepburn and Dr. Parker. African Americans, you probably have heard on other of our talks, are 2 to 3 times more likely to develop Alzheimer's disease. So they're very important to research. And we really need to understand the risk factors that contribute to this disparity in outcome. So that's a big goal of our center. We also, Dr. Hajjar spoke about the clinical trials unit. Another function of our core is to support recruitment. So from participating in the clinical core, we identify people who can be in other research studies going on at Emory, including pharmacological clinical trials, but also non-pharmacological studies that you've heard about, aerobics, tango, just a group of different studies that are available. We help to identify when we meet weekly to go over people who are in our core. We discuss what studies they particularly might be interested in and what they might be interested in participating in. We also support national and international efforts. So we work closely with ADRCs and other institutions across the United States and worldwide to give them biospecimens that we've collected here, brains that we've collected, because we, as Dr. Alonso mentioned, we really need a large database to be able to make meaningful discoveries. And so by participating in those, we contribute millions across the United States and worldwide data that can be analyzed and looked at. This just shows you, this slide is actually our composition of our Alzheimer's Center in February when we submitted our renewal of our grant. It's actually grown since then. But you can see here that at the bottom, we have 261 people who are controls, meaning, as Dr. Parker mentioned earlier, those are people who are doing well on our neuropsychological measures. Families aren't reporting any problems. The patients aren't reporting problems. We have 65 individuals at that point with mild cognitive impairment and 51 with Alzheimer's, and 20 with other causes of cognitive impairment besides Alzheimer's disease. Currently, we have 419 active participants in our clinical core. One thing I want to point out that's been mentioned by Dr. Law, you notice that we have, at that point in February, we had 148 males, 271 females. So we need to up the representation of males in our clinical core, and the outreach recruitment core and minority recruitment cores have really been trying to actively recruit male participation. It's so important to understand whether there are any gender inequities, which we know females are more at risk, but to understand why that is. Again, the thing that I did mention in parentheses, you have the representation of African Americans. We are getting there. We have about 50% of our new participants who are African American. We continuously are recruiting throughout Atlanta and surrounding areas to up that as well. Another function of our clinical core is to really try to advance biomarker discovery efforts. We are collecting not only neuropsychological data and questionnaire data, but we are also collecting biomarkers. And one of the things we ask people who are enrolled in our clinical core and in our Alzheimer's Center to do is to consider not only brain donation, but also donating genetic material, blood, and cerebral spinal fluid. This information is critical, again, for helping to understand risk factors for development of Alzheimer's and related diseases. We coordinate with the biomarker core and the data management core to share biospecimens. And again, we send these specimens across the United States and around the world for sharing with other scientists. This just shows you the biomarker layout. There's a preclinical stage of Alzheimer's disease. It's the second bar from the left. The reason biomarkers are so important is because there's evidence that we can identify Alzheimer pathology even before people are exhibiting any symptoms. So there's a preclinical stage, typically where the individual subjectively knows that something's wrong, but they're performing well on testing, that they go to their doctor, the doctor says, hey, there's nothing wrong with you, you're fine, you're just getting older, stop worrying, but something is wrong. By getting cerebral spinal fluid and MRI scans and all, we can see changes that aren't detectable to the human eye or by our standard tests. The goal of our research and across the world, of course, is to identify people in this preclinical stage when treatments are most likely to be effective before the stage of mild cognitive impairment and dementia. So we really encourage people to help us by donating specimens for us to be able to analyze and get at who's at risk for the MCI-AD transition eventually. And finally, we have expanded. So, the focus, we're called an Alzheimer's Disease Research Center, but we actually do much more or see much more than Alzheimer's disease. In this latest reiteration of our renewal of our center, we are now also including vascular cognitive impairment, people with mini strokes or undetectable strokes, but they're seen on imaging, and also with people who have Lewy body diseases. These are not pure Parkinson's, but Parkinson's-like syndromes. So we've incorporated now expanded cardiovascular phenotyping. We're getting blood pressure. Some of Dr. Hajjar's cardiovascular measurements are being given as well, so we can really understand the interplay between vascular disease and Alzheimer pathology. We are also have expanded our cohort to include Lewy body disease, people with Parkinson's, and people with Parkinson's dementia. We know, and I'll just show you, that Alzheimer's disease is the most common cause of dementia, but these other types of dementia too play an important role. They're either by themselves, or more likely when people come to neuropathology in our center, we see a mixture. It's rare for us to just see Alzheimer's disease only. Typically we'll see Lewy bodies, or we'll see mini strokes that have happened that we weren't even aware existed when the person was alive. And it's really critical to understand this. I just wanted to mention, because others have said what's going on, we talked about air pollution as a risk factor for Alzheimer's, but one of the things that we're going to be participating in as an ADRC is it's called the Neighborhood Study. It's a multi-million-dollar project funded by the NIH. It's just beginning. It's out of the University of Wisconsin, led by Wisconsin's ADRC, but we're one of the contributors to it. We're interested, or the over 20 centers across the United States are going to be participating. We're interested in factors such as how socioeconomic status, noise levels, crime levels in certain neighborhoods contribute to the heightened risk of dementia, including Alzheimer's disease. There's some exciting research showing that not only air pollution, but these other factors play a role. We've also gotten interested more and more in the use of technology to measure cognition. So up to now, most people have been coming in for testing in our clinics, paper and pencil testing. We've adapted some of our tests to be done on the telephone because of COVID. We're trying to develop iPad administration, mobile phone administration, so people don't have to come to the center necessarily to get their memory tested or other cognition abilities. Some of you have been in a NIH toolbox study where we have given you an iPad and you've come in and we've measured your thinking abilities. One day the iPad may substitute having to come into the clinic for cognitive testing for neuropsychology. And finally, I wanted to mention a lot of studies now are going on in our clinical core. There's a real interest in passive measurement. So we're interested in using technology to measure changes like gait, balance, speech. There's evidence, Dr. Hajjar is publishing a study showing that changes in speech occur years before someone even exhibits Alzheimer's disease. Changes in speech, choice of words, how someone describes a picture. You can pick up these subtle changes early on. So we're real excited about that too. And this is some of the new directions our center is going in. And that's about it for the clinical core. If there's anything, questions, or if anything I can help with, please let me know either by chat, or you can email me at fgoldst@emory.edu, and I'll be glad to speak with you as well.
Dr. Goldstein, while you're there, can you tell people how they may go about getting a neuropsychological test? You're not the only neuropsychologist around, and I know we don't want to overwhelm you, but how might a family member go about getting that kind of testing for their relative?
Right now, the way that we are doing it, at least at Emory in the cognitive neuropsychology program, is we are taking referrals from doctors at Emory. So if you suspect one of your family members or yourself are having some problems, please alert your provider at Emory. You can request a neuropsychological evaluation. I always tell people, if you know something's wrong, even if your doctor says, nah, nothing's wrong, but you really think there is, you should insist on getting an evaluation. It's not just myself, we have 4 other neuropsychologists who can see you too. There is a rather long wait. There are also very good people in the community. I'd recommend that you get on the neuropsychology board, BOARD, of American Board of Professional Psychologists. Go to clinical neuropsychology. I recommend you get a board certified neuropsychologist to see you. They list them who's such in Georgia and by location. And I'd recommend, if you can't be seen at Emory for some reason, that you go to someone who's at least got the credentials to see you.
Okay. Thank you, Dr. Goldstein. I really appreciate that. But while you're there, I can answer this. But can you tell people the difference between mild cognitive impairment versus mild dementia? That's one of the questions that's in the chat.
Yeah.
Would you kindly explain that to people?
Yeah.
You and I are it, so we're going to finish out these last 8 minutes.
Okay, that's fine with me. That's a difficult distinction, but basically, both mild cognitive impairment and mild dementia, both are characterized by cognitive impairment. So people have cognitive issues at both stages. The important difference has to do with your activities of daily living. If you are still able to drive safely, you may still be working, you may be doing your own bills and managing your medications independently. If you're still able to do all that pretty independently, you may need a little bit of help, but basically you're on your own. You're given a diagnosis of mild cognitive impairment. If you, on the other hand, your loved one comes in and says to the doctor, you know, he's missing a lot of doses. I have to stay on top of the medication. I'm worried about his driving. He's gotten into accidents or gotten lost. If it becomes to that level, then the doctor will diagnose mild dementia. So it really has to do with how you're functioning on a day-to-day basis.
Thank you, Dr. Goldstein. Okay, I have another question here. For any of the panelists that are still here, if you can chime in here, looks like Dr. Hepburn's still here. One of the questions I have is, when blood samples are collected and there is evidence of disease, mild or otherwise, how is it treated? Where and how can I get evaluated? Okay, I think this is a good question. And I'm going to go back to something I said earlier. When you have a concern about how your brain or that of somebody you love is functioning, consult with your primary care doctor first so that they can rule out those things that are treatable. Your primary care doctor can then refer you to a neurologist. If you're in the Emory system, you'll come to the cognitive neurology department here. If you're not, you see your community-based neurologist who makes the referral to your primary care doctor, and let them do the kinds of assessments that are necessary. The neuropsychological exam, again, as I mentioned before, that's another part of this exam. So getting a diagnosis of dementia is a multi-part kind of process. It's a process. You can't just run in and get one test and get it done. The neurologist, as long as all of the medical things have been evaluated and you've ordered an MRI or a PET scan, the neurologist is probably going to ask you some more questions, but more importantly, the neurologist is probably going to conduct a lumbar puncture to look for the precursor proteins that are associated with Alzheimer's, and that's the A beta and the tau protein in the cerebrospinal fluid. So I know that there are a lot of us that are watching that are like, I'm not going to get a needle in my back, but what you need to appreciate is that right now there is only one FDA-approved test that is diagnostic for Alzheimer's, and that is an amyloid PET scan. An amyloid PET scan is usually accessed through a research institution. Medicare and your insurance doesn't pay for it. These scans are over $6,000, okay? Your insurance doesn't pay for it. Right now, the best way that you can access that is through a clinical research study. The other thing is that we are developing blood biomarkers for detecting and diagnosing Alzheimer's disease specifically. Those blood biomarkers are not yet available widely. They are available through research and they're being tested. But some of the other things that we're talking to you about are things that we need to do. Okay? So I hope that helps you with the evaluation you need, okay?
Monica?
Dr. Hepburn?
Yeah, I wanted to jump in on this conversation. This is so critically important. And we talk a lot in this forum and in other forums about Alzheimer's disease as though it's the only dementia. But it isn't. And I think it's really important to recognize that there are other dementias as well as Alzheimer's, that show up in individuals under the age of 65. That means these are individuals who are not going to have regular Medicare-based cognitive screening done because they're not yet Medicare eligible. And yet they're showing signs and symptoms of having a neurocognitive illness. Basically, the literature documents that these individuals spend years going from doctor to doctor, saying, what's wrong with me, and not getting a good clinical workup. The thing that is advantageous about the Alzheimer's Disease Research Center and the clinical neurology service is that there's expertise here that really understands that there are some illnesses that unfortunately occur in younger people. And so if you are in a situation, or if you have friends in situations that they're going from doctor to doctor, not getting clear answers, it isn't just any neurologist who can do this. It isn't just any neuropsychologist. You really need to go to experts who appreciate that these disorders can occur in people younger than age 65. So probably 500,000 people who have Alzheimer's are under the age of 65. And a good many of the people who are affected by frontotemporal dementia are under the age of 65. And Lewy body dementia also occurs in people under the age of 65. So we probably should emphasize that this is not just a disease of aging.
Can you open me up? Thank you, Dr. Hepburn. That's very important for people to appreciate. As Dr. Goldstein has answered your questions with respect to mild cognitive impairment and dementia, and Dr. Hepburn has added on and appropriately let you know that all different types of dementia are not the same. And as Dr. Goldstein and Dr. Alonso pointed out, you can have combinations of different features of different types of dementia, and it takes a lot of work to sort that out. There's no it's not like a pregnancy test. You can't go in, get one test, and get a blue stripe, and it's like, okay, there's my diagnosis. It's a process. It's an ongoing, developing process, and as time progresses and as research progresses, we're getting a little bit more specific about how we make these diagnoses. We know that cerebrospinal fluid gives us a better bead on Alzheimer's disease, but not necessarily some of the other ones that we've talked about. So now one of the questions in the chat that I haven't answered, it says collecting data at the preclinical stage via MRI. Why are you collecting all this data? Simply because you have to look at trends and you don't know what to look for until you see patterns. So you collect data. I know it sounds very scientific and sometimes it's not easy to understand, but doctors have to look at symptoms and they have to look at an accumulation of symptoms before they can order the correct tests such that they can arrive at the correct diagnosis. So whether it's heart disease, some kind of rheumatologic disorder, or even Alzheimer's and related dementias, we have to look at a constellation of things: clinical features, lifestyle features, things that you may find in blood, things that you may find in cerebrospinal fluid, things that you may find on a specific kind of image. So a lot of times in science, we don't necessarily know what we're looking for, but we start studying and looking at things. That's why now we're looking at air pollution as a major risk factor for developing dementing diagnoses. So that's what we hope to accomplish by collecting data. We have exactly 1 more minute, and I'm looking in this chat trying to see what else I can answer. So the investigators, wherever it is we are within this system and any place else in the world where we're studying Alzheimer's and related dementia, they're accumulating and and looking at different kinds of data before they can figure out what's actually going on. And that's the process of research. And that's why we want those of us that are healthy, those of us that are not so healthy or have cognitive impairment from whatever cause, and those of us who have full-blown dementia. We want all of us to participate in research. Next week, we're going to have part 2 of our Alzheimer's Disease Research Center Spring Forum. Again, we're going to feature more people from our Alzheimer's Disease Research Center. And yes, you have to tune in a little bit earlier. It's not 2 o'clock next week, it's 1 o'clock, okay? John's going to come on at 12:55. You're going to have 5 minutes, and you're going to have 90 minutes of program. So we hope to see you all next week. You're going to have more Alzheimer's Disease Research Center investigators and other program persons participating next week. Hope to see you again next week. We'll leave the chat up. Sign in for Eventbrite for next week's part 2 of our Alzheimer's Disease Research Center Spring Forum 2021. Thank you for your participation today.
Thank you.